the emotional journey is also difficult. The resilience from an emotional perspective is so important for us patients and caregivers. And so Dr. Kassab will enlighten us.
Thank you, Adele. Actually, thank you for inviting me today, and it's a privilege to be able to be with all of you. About 3 months ago, I retired as Director of Psychiatry and Psychology at the Morris Cancer Center at UCSD. That's where Joel knew where I was when you talked to invite me. I still teach, I still supervise residents, I just don't see patients anymore. I've been a doctor for 42 years. But really, I wanted to introduce to you the concept of psycho-oncology. First of all, cancer is a devastating illness, as we all know, with physical, emotional, interpersonal, and social implications. And that should be constantly monitored throughout the disease trajectory. Now, cancer is not just one thing. It's complicated, right? It's a disorder of change. It's unpredictable, so we don't really know what's happening, right? So it's important for the family and the patient to be addressed, for us to address the issues that come with it. Now for you, particularly for this particular cancer, appendix and PMP, it's rare. And it's not like breast cancer where you have so many people, you can talk, and there's groups, and there's all that kind of thing. But for PMP and appendix cancer, it's rare. But thank God for PMP Pals. And this is actually the first time that I heard about PMP Pals, and I'm actually quite privileged to have been allowed to know about this. So it really is important. Psychosocial assessment is important. And all the cancer organizations, American College of Surgeons, Commission on Cancer, the National Comprehensive Cancer Network, the American Society of Clinical Oncology, and COPI, which is the Quality Oncology Practice Initiative, all of these require that psychosocial assessment should be done in all patients with cancer. In fact, the Commission on Cancer will accredit an institution only if they meet all of the standards, and one of the standards is 3.2, which is every year there has to be a psychosocial distress screening for all cancer patients and referral for psychosocial care. And that is where psycho-oncology comes in. What is psycho-oncology? Psycho-oncology is a subspecialty of consultation liaison psychiatry. Another name for CL psychiatry, consultation liaison psychiatry, is psychiatry in the medically ill or psychosomatic medicine. It is an American Board of Psychiatry and Neurology certified subspecialty in psychiatry. And what we do as psycho-oncologists is to address two major psychological dimensions of cancer: the psychological responses of patients and their families patients with cancer and their families through all the stages of cancer, and also the caregivers who may not be family as well. And also the psychological, behavioral, and social factors that may influence the disease process. And psycho-oncology connects various disciplines. We have to talk to the oncologists, the surgeons, the psychiatry, psychology, social work, nursing, radiotherapists, palliative care. We work together with all of these disciplines so that we can provide the optimal care, psychosocial care for cancer patients. So what happens when somebody is diagnosed with cancer initially? Of course, there's the fear. You're told you have cancer. There's the fear of dying. There's the fear of permanent disability. There's worry about medical uncertainty, worrying about cancer's impact on their life trajectory, and the fear of suffering a painful death. These are fears in the initial diagnosis of cancer. But cancer has several crises as we go through its trajectory. Initially, hearing the diagnosis is a crisis. Finding out that you have a poor prognosis is a crisis. Finding out that your treatment is not working is a crisis. Finding out that you're going to have the cancer again, the recurrence of cancer is a crisis. Losing body parts is a crisis. Being estranged from family and friends is a crisis. Financial setbacks is a crisis. Irreversible side effects is a crisis. And then being transitioned to palliative care is a crisis. So all of these are very important psychosocial events in the patient with cancer and their families. What are the factors involved in the impact of cancer on patients? The existential threat of the disease, dying, and so on and so forth. The psychosocial consequences of the disease, the consequences of the morbid disease process, and the treatment and its side effects. But there are certain patients who are at high risk for problematic coping, and there are those that are able to cope. And what are these characteristics? Well, if they have a history of psychiatric vulnerability for depression or anxiety, if they have a family history of psychiatric problems such as mood and anxiety, if they are currently using substances or have a history of past substance use disorder, if they have poor social supports, and in socioeconomically stressed families where the patient with cancer is a primary financial earner. These kinds of characteristics kind of put the patient at high risk for problematic coping. Now, as a psycho-oncologist, one of the things that I do as a psychiatrist is to diagnose depression, and anxiety, and that's my work that I have done for a long time. And talking about depression, the prevalence of depression, or not really depression itself, because depression has a spectrum. Major depression, adjustment disorder, depressive disorder, there's all these different diagnoses of depression. There's about 38% of the depression spectrum disorders that are found in patients with cancer. And this doesn't mean that they had depression before. This is what they had cancer and then they had depression. Now, why is that important? If you're depressed, adherence is one of the things that is affected. If you are depressed, you have the reduced capacity to understand what's being told to you. I think we talked about that earlier, right? I mean, that's why you need somebody else with you when you're talking to your doctor, because if you're depressed and somebody's talking, you just heard the cancer diagnosis, what? That's it, we're done, That's why you need somebody there. There's difficulty planning attendance for anti-cancer treatments. I'm so depressed, I don't want to get out of bed. So you have an appointment with chemo today, the infusion center is expecting you. Well, too bad, Decreased motivation for self-care and healthy behaviors. Self-explanatory. Pessimism about the treatment and its effects. Greater difficulty tolerating treatment side effects. People with depression, their perception of pain is higher than people without depression, everything else equal. Okay, so that is a problem. Social isolation and withdrawal. And withdrawal of family, very important as well. Poor family support is very important. And then when they're depressed, they don't want community. Who wants to call PMP Pals? Who wants to do any of those things? When they're depressed, that's what happens. And that is why it is important that we attend to the psychosocial aspects of the patient. We need to treat the patient as a whole, not just this cancer here, not just here. We also need to treat here. Okay. Now, there has been in cancer care a syndrome that people call demoralization. And demoralization is about, Dr. Hussain is actually, who was he was in Australia and then he was recruited to be chief of psychiatry at Memorial Sloan Kettering, then he went back to Australia. He is a proponent of the syndrome of demoralization, which is different from depression. His proposed criteria include loss of meaning or purpose in life, loss of hope for a worthwhile future, sense of being trapped or pessimistic, feel like giving up, unable to cope with predicaments, socially isolated or alienated, potential suicidal thinking, and the phenomena persists for more than 2 weeks. Now, depression is treated with medications and therapy. Demoralization is treated, if it's only alone, if there is no depression, then it's treated with psychotherapy. There are certain psychotherapies that are used in those particular cases. So, as psychologists at Moore's Cancer Center, our psychiatric services also have psychologists that provide this psychotherapy as well. When a patient is with cancer, there are long-term challenges with cancer care. Dealing with uncertainty. I mean, you had asked Dr. Baumgartner that actually said, we don't know what's going to happen, right? So dealing with uncertainty brings anxiety, right? I mean, what you don't know, it's going to cause you to be anxious, right? Dealing with side effects and disabilities caused by cancer and cancer drugs. Dealing with dependence on others, particularly if you're someone who is kind of macho, independent, I'm the man of the family kind of thing, and then now you have to have somebody help you out. You can't live without somebody helping you out. Maintaining self-esteem. We all depend on our identity and to be productive citizens, and we are not productive, our self-esteem goes down. So maintaining that self-esteem is important. Maintaining important connections with your family, your friends, your workplace colleagues. Financial challenges. Again, we talked about how if you are the financial earner for the family and you're laid down, how can you provide that? So there's that challenge. But aside from that, cancer care is very expensive. Thousands for those medications, right? And you're lucky if you have insurance, but even with insurance, you spend so much money. So there's a lot of that challenge there too. And then family entanglements. In long term, you have family members who kind of got sick and tired, they feel that they can't do this anymore, You have friends who were there in the beginning, they were visiting every day and then slowly gone, So these are long-term challenges to the individual in cancer care. I'm talking about families. There are families who are very resilient and there are families who are not quite resilient. So what are the variables about family resilience? Families who have lack of emotional support in the family. When the patient is withdrawing or when the family is withdrawing. Very rigid families. Feelings of helplessness, resentment, loneliness, blaming. Oh, that's because you did not do this, and you did not do that, and you ate this, and that kind of stuff. Covert communication. Instead of open communication, don't tell him, just keep it between the two of us, and isolation. So these are variables that affect resilience in families. But there are those families who have high resilience. And how is that? What are the variables? When the family as a whole have common values. When the family finds meaning in adversity. When the family is flexible. When the family is open. when the family solves problems together and grow in the adversity, become closer in the adversity, and open communication, talking about how one feels. Because face it, you can't be all the time happy, or you can't be all the time not saying anything. You have to tell, I feel bad, I feel this way, or I didn't like the fact that you did this, Even if it's to the patient that has the cancer, you have to be open, you have to tell each other. Now, as psycho-oncologists, we do family intervention. We see families together. And when we see families, our focus is on the family structure and dynamics. Every family is different. We look at the gender, the age, the education, the socioeconomic status, the culture, and the religious beliefs of each of the family members. What's the medical status of the patient? What's their perception of the patient's illness? And what are the treatment consequences? What's the communication between the patient and family, between the patient and family and the healthcare team? And what's the degree of the objective and subjective burden that is experienced by the family? Oh, sorry. And then the extent to which the disease is perceived as a threat or a life challenge. Past meaningful events in their lives, and how do they cope with it? What is the locus of attribution that's made for the disease and the cancer-related outcomes? And the meaning that is made from the personal experience of suffering? And the availability of a network of friends and family members who can provide the emotional support. Now, we also not just treat the family as a whole, but we also treat children, of patients with cancer. Now, when we consider children with cancer, we have to consider what stage they are in. Okay. For example, infants and toddlers. You should not make discussions in front of these kids. It's not that they understand because they don't understand. However, they're tuned into the emotional tone of the conversation. So it's important to avoid that. They also have to have some consistency, some routine, no changes, and no multiple caregivers, because then they kind of, what's going on here, And the preschool age, they may have heard some conversation, and then they see that there's so much change happening with the father or the mother. And because of their age, they think, that's because of me. I caused that. So it's important to let them know that it's not you. It's not you. And also give them some routine so that they are not affected. Now, school-age children may know that there's cancer and people can die, So they don't want to, you want to give them, again, routine. You don't want them to have something that's different. Then we have the early adolescents who more or less know what's going on, okay? And sometimes they are embarrassed to show emotions. And so the tendency is to kind of withdraw when they are upset. So it's important, again, open communication. That's what's important. Late adolescents, these are people who already know more or less what the situation is. And they want details. They want to be involved. They want to make sure that they're included in the conversation. So that's important. And then we have the young adults. These are the people who already, the children who want to be close to the house, close to the home. They want to be there because they want to take care. It reminds me of a patient of mine for a while, for many years, whose 19-year-old son was in college in Arizona. And he decided he's not going to continue school in Arizona. He would come back home to be with his mother who has cancer. So this kind of what happens with the young adults. So aside from the children, the family members, there are, again, another group of psychosocial stressors that patients have. And this is what you already know, the effects of treatment, you know. In particular, the effects of high-tech and CRS, and you have Dr. Baumgartner there, and the other doctor also, you know, there's all these different side effects. I am not an oncologist, so I will not bother, but I do know about side effects. Right? My patients complain to me about side effects. So there they are. I'm not going to go through all of them. Actually, I think I got that from PMP Pals. So you know that. But you know what? So you finish treatment, you're staying there, and you know what's the most common thing that happens? FCR. Fear of cancer recurrence. Okay? It's the fear, the worry, the concern that cancer will return or cancer will progress. And this is a common unmet need among survivors of cancer. And when persistent and excessive, it leaves the individual at risk for depression, impaired daily functioning, using unnecessary health assessments, and a reduced quality of life. We actually in Moore's Cancer Center, because there's only so much of us and there's so many cancer patients, we actually limit ourselves to patients who are actively under treatment. However, when the patient has fear of cancer recurrence, we take them back. Okay, so we do take survivors as well. So what are the concerns of survivors? They're worried that there will be delayed medical complications. I think we were talking about that earlier, right? Organ failure, cognitive impairment, infertility, second cancers, fatigue. You know, these are all later on complications that survivors are worried about. The fear of termination of treatment, the fear of cancer recurrences and death, difficulty with re-entry into normal life, persistent guilt, difficult adjustment to physical losses, diminished self-esteem or self-confidence, changes in work roles or even reduced schedules, fear of job and insurance discrimination. And I have seen a fair number of survivors myself, and I can tell you that these psychological concerns are quite valid. One of the other psychological concerns for patients who are survivors are problems with the loved ones. Families expect the patient to do what he or she did before cancer. They think that, you know, they've been doing this all the while that you've been in treatment, and now you're a survivor, so how about you doing that again? You take care of the house and the garden and the yard, you know, you can do that. But then you're not yet ready to do that, okay? So it's a problem, right? The patient with cancer expects more from their family than they receive. When you were under treatment, when you were being having surgery and having chemo or whatever else, they were with you, they were visiting you, they were paying you a lot of attention. Now you're a survivor and you're not getting the same attention. So that's a problem. And then the fact that you may need to be dependent on others still, it's not yet done. You're not back to normal. I can't say that for a lot of you are decades survivors, but you know, it happens to some people. So I'm not saying that it happens to everybody. One of the other aspects of problems, psychosocial aspects that we see in this trajectory of cancer is dying. Okay. So there are challenges to the dying patient. There's the loss of control. You know, death is sometimes not feared as much as the loss of control. You have no control of when, where, how, you know. So that loss of control is quite challenging. Facing uncertainty not knowing what's going to happen, and separation, knowing that your days are numbered, stuff like that. And then facing the future and reflecting on the past. Now here, we actually at Force, we do several kinds of therapies for the dying patient. We do meaning-centered therapy, where you find meaning in your life, and dignity therapy, where you look at, you reflect on the past, you look at the future, what do you want to leave as a legacy document for your family, for your children? What is it that you can do? We have a certified dignity therapist at Morse, and she has done several of my patients, and they are beautiful books where there's different kinds. Where there's a book from a doctor who has since passed away, where he wrote letters to his kids. There's another one that showed pictures to his kids. We make it into a book, so it's something that the family will get when the patient passes away. I would be remiss if I don't talk about COVID-19. Okay, COVID-19 has resulted in new sources of anxiety and stress for many cancer patients and survivors. For several reasons. It has added a significant burden. There's been, steps taken by hospitals and healthcare systems, ours included, where there's a lockdown. So your scheduled chemotherapy, you can't go. Your scheduled surgery, it's not going to happen. It's going to be postponed, stuff like that. And then we have the fact that there's a lockdown, so you can't go with your loved one. The loved one is alone in a prolonged hospitalization. The loved one is alone dying with the family on the phone or on FaceTime. Not there, not touching. That is an added burden, a very big added burden. And more practically, you're immunocompromised. And so being exposed to COVID-19 will make things worse for you. So these are effects of COVID-19 on the patients. So I hope that I have been able to explain to you what a psycho-oncologist does, what are the psychosocial effects of cancer on patients and families. So I would be open to questions if anybody wants to. Yes?
It's so important. Your topic and your subject is so important. And I'm wondering, it's available at your institution. How is it across the United States? And,
City of Hope has one.
and is it covered at all by insurance?
Yes. It depends, by the way. It depends on what you're going to do, But we are covered by insurance. Most of I belong to the American Psychosocial Oncology Society, and it's multidisciplinary, psychiatrists, psychologists, etc. And I know a lot of psychiatrists across the board that are offering similar services in their particular cancer centers. And most of the psycho-oncologists work in cancer centers. We are embedded in the cancer centers. We're part of the team. So yes. It depends on what, sometimes there's certain things that they won't approve, but in general, they are approved. That's how we get our funding. Yes?
So is your service only inpatient, or do you also?
No. It's outpatient. It's not just inpatient, it's outpatient. Actually, when I was in UCSD, I was seeing patients every day. So it is, and then I also see patients in consult. Yes?
Does your oncologist have to refer you, or how do you?
We get referrals from oncologists. When I first came to UCSD, I went to every team. and explain to them what the process is. Our cancer committee, I give reports every year on what we're doing. Actually, before I came, there was only one half day of psychiatry and several half days of psychology services. When I was there, it was every day. So, and somebody replaced me, so I hope that happens still. Yes.
First of all, thank you for this. I agree. This is this element of treatment is just so important, and it's really necessary. You talked a lot about patients. Is there similar type of therapy or support for the caregivers? 'Cause
Yes, that was what I was saying. We address caregivers, we address patients, families, children.
Okay, so for example, through UCSD, a caregiver can get access to that.
I had for a long time a caregiver of a patient, not necessarily a spouse, you know,
Right.
but as long as we can prove, now the caregiver has to be registered, you know, but that's UCSD. You know, you have to be registered and all of that kind of stuff. And if their insurance does not accept us, because we don't accept all insurances, we refer them out. Yes.
One thing that we hear in PALS a lot with our support groups on Zoom is patients' families withdrawing. You know, you touched on that, and it's just such a common problem, and it's very hurtful, and it comes on top of all the other challenges that are being dealt with. When you're working with a patient, what can a patient do to rebuild those bridges or improve that situation?
What we have done is that let's say I said, we deal with families, so we talk to both. Remember the identified family, the patient with cancer and the identified family that is an issue, and we try to help them. We do couples, and we actually also contract with, for couples, we contract with someone in particular. We got a grant for one of our benefactors to see patients in couples therapy. So we do couples ourselves too, but let's say they don't have insurance and stuff like that. We have that. So what happens is that's what's important is the communication. So you bring them in. What's the problem? What is it? Let's kind of explore that, and hopefully that will help solve the problem. Yes.
It almost seems like that should be a requirement, you know. That
But it is a requirement by COC, but not all cancer centers are NCI designated. Our cancer center is NCI designated, and so it's a requirement for us. So certain cancer centers, it's not a requirement maybe because they're not NCI designated, but to be NCI designated, you have to have this service.
But is it offered? I mean, is that what you're saying? You have to have it, and I think for all cancer patients, it should be an offered service.
Yeah,
Not uncovered, but an offered service.
That's yummy, yes.
I would say thank you for putting this in black and white, because when you're in the middle of this, nothing is normal.
Mm-hmm.
And all of these emotional impacts feel even less normal, particularly in a society that says that's in your head.
Exactly.
And so seeing it in black and white and saying, this is normal. When you're in this place, this is totally normal to go through, feels so balancing. It feels so, not relaxing, because that's hard to relax, but you know, it feels like it's almost like it's okay to not be okay.
Yes.
It's okay.
Yes.
It's
And actually, that's what we tell
okay.
patients. It's okay not to be okay. Yes.
When do you step into the process? Is it, when do you step into the process? Is it in the initial diagnosis or the?
I usually, we are a referral. We're a consulting service. So they would have to put in a consult. It doesn't have to be the doctor, it could be a nurse practitioner, it could be the nurses, it could be anybody in the cell care team that tell us. Oftentimes, I've noticed in the years that I've been in UCSD, when somebody's told and they are reacting quite severely, I get called and I go to the clinic and I, talk. We have social workers that do that too. So our social workers have been our first line, and if they feel that they need a psychiatrist or psychologist, they call us. Yes.
If I was interested, and I'm interested in utilizing the service, where do I go, what do I do, how do I find someone like you on the other side of the
It depends on where you are. Where's your, I can tell you which places have psychosocial.
I'm in Baltimore, Johns Hopkins. Baltimore, Johns Hopkins.
Oh, Johns Hopkins has one.
Yeah, so how do I ask my?
Yes, ask your oncologist to
Okay.
refer you to psychology.
Awesome, thank you.
Yes?
I was waiting because I was wondering if I was going to hear it from you. But I've been saying it for years that as visible as our treatment is, the emotional aspect is more difficult than the physical aspect. The question I was going to ask is what percentage of patients do we think end up getting this type of care? That was kind of my question, but as Libby said, thank you for hearing us, and thank you for opening the dialogue on this topic.
Yeah, not enough.
Yeah, not enough.
Not enough.
Yeah.
And we are also understaffed.
Of
We,
course.
there needs to be, I was the only psychiatrist that's full-time, and then we had 1/2 day a week psychiatrist. And we have so many patients, so it's crazy.
I'm looking at the ERAS word,
Yes.
and I'm thinking,
Yeah.
need a psychosocial
ERAS.
person, right?
Yes.
Who is a champion and starting slow and
You
these
will go
bubble
through
checks on the board to think about. But
Well, the funding is a different one.
Yeah.
I almost left a year ago when they said they were gonna take out my funding. And I said, oh, if you take out my funding, I'm out of here. But they put it back.
I want to just follow up with what Chris said, and everybody in this room who's been on our Zoom calls knows this. PMP Pals strongly supports people getting therapy, help with their emotions, with their family situations. We strongly encourage people to seek out services at that time because we believe it's necessary and it works. And, it helps to relieve the crisis that people are going through emotionally. So we're very supportive of that. We talk about it all the time, and it's something we strongly support and believe in our
Yeah, psychosocial assessment and treatment is a critical cornerstone in comprehensive cancer care. So it is. Yes, sir.
It took me about 20 times to hear Chris actually say that until I believed it. And I appreciate that.
What do you do for a living?
What everybody has to realize is there's a huge staffing issue, namely
Yes.
psychiatry. You can't imagine how difficult it is. However, telehealth and a compact, if you want to get involved politically, we have a lot of states represented here. What we want to pay attention to is a mental health compact, so that a clinician in Pennsylvania can see someone from California. You cannot believe the limitations we have.
Yes.
However, a lot of movement has happened in the last year and a half that clinicians couldn't imagine. And so, be encouraged, be a good advocate. But one other area that's really exciting to me is, and I mentioned to most of you have an employee assistance program. 20 years ago, they didn't exist. And if there's a tragedy that mistake, if there's an issue with your company, frankly, the motivation is litigious. Newsflash, right? I mean, it's a liability protection. But your employers do a great job of accessing even an overworked staff. In areas of suicide prevention, there's ways in which we as a society prioritize. We said this is important enough that we want to have, what was your word, accessibility, not compliance, but just the offer. But you can tell from what's going on here in the intro And I would just, I think there's a way in which we, through accrediting agencies, that sort of thing, really just insist that it should be provided. And historically, it's a very, frankly, you'd be surprised how low percentage of people will actually access mental health services. That's changed as well. And it's fashionable, right? We used to have to escort people to the back door. Yes, doctor, you know, and now I'm in therapy. Hello,
Yes.
you know, it's a bad
There's still stigma though, but,
Okay, yeah,
but it has changed. It has
unfortunately,
changed
there's
a bit.
some really exciting ways that we can navigate it. So that compact clause, okay, get parity for mental health clinicians and utilize Zoom, Zoom,
Actually,
PMP telehealth.
yeah, actually, our disease team, we call ourselves disease teams in UCSD. Our disease team was able to 100% to tele in the peak of the pandemic for the last 3 years. But pre-pandemic, I was asking that I be allowed to do telehealth because I have patients from Murrieta, from, you know, way up north, to way east and way south, that will take 1 hour to 2 hours to get to me for an hour, half hour. Come on, let's be real here. And then they're ill. They're not feeling good. I mean, that's the time that they need to talk to us, you know? So I was asking for tele, and thank God, no. One of the good things that happened from the pandemic was we got that. Without all their, red ribbon, what do you call that? Red tape, thank you. Any other questions? Well, thank you. I will still be here available, and I will be